Okay, thank you. Thank you also to Diane and Armel for those presentations. There's as we saw from earlier slides, there's been a whole load of people involved in the work on ALCOVE, and I think one of the great things for all of us that participated in it is that sense of greater community now across those of us working in different countries, and recognising that many of the issues that we face within our countries have a shared concern in other countries, and also an appreciation of the thoughtfulness and care that goes on around providing services for people with dementia. So I've put up here the key members of the team that worked particularly around timely diagnosis. My team at University of Worcester, the Association for Dementia Studies, the Department of Health England, and also our steering group that incorporated both people living with dementia, family carers, Diane from the Alzheimer Europe, and people who are very active in the practice of diagnosis and issues around early cognitive change. This diagram from Martin Prince and colleagues from the World Alzheimer's Report in 2011 was a very useful one for us when we first started to concentrate on our work on timely diagnosis. And my guess is this may well be familiar to many people in the room. Who knows this? None of you? It's a very useful one. One of the things that we hit early on in our work package was when we started to talk about early diagnosis. If we talked about early diagnosis to neurologists and scientists, actually what they meant by early diagnosis was the earliest possible diagnosis when we've got some onset of neuropathology, or earliest possible diagnosis using currently available technology, which is really early. And we had many discussions about what we meant by early diagnosis, and we have then plumped for this term of timely diagnosis. And it's not just about the semantics of that. We're not just inventing a new word for the sake of it. But I think we were very concerned that we wanted to look at the benefits of diagnosis at the point where the person with dementia and their family are help seeking. So when people are first starting to notice significant changes in cognitive function and going to their general practitioner or talking to people in their family about it. And recognising that post-dates, we think by many years, the onset of neuropathology and some of the onset of cognitive decline. And it's that period of time, really, when timely diagnosis is responding to patient and carer concerns rather than proactively screening for the disease. That's not to say that this diagnosis at these really early stages is important, because certainly from a biological point of view, from a treatment point of view, we really need that sort of work to continue. But within the ALCOVE recommendations, what we're looking at is moving from our current late stage diagnosis, when we're diagnosing at a time when it's too late to do your advanced directives, it's too late to make all those family adjustments, but rather shifting to this, what Prince et al. Called T3, that timely diagnosis stage. And it's very easy when we look at diagrams like that to think that there is a day when suddenly things change. There's a day when that diagnosis becomes a rigid thing. And another key quote for us when we were looking at our literature review was this one from Jill Manthorpe, who often puts things very succinctly. And she hit, I think, on something important here when she said, dementia is not something that suddenly happens to you, that suddenly you're a different person in need of help. This is a complicated and slow process of internal recognition for the person that something's not quite right, and an acknowledgement, and then the external acknowledgement within families and relationships, and finally a slow journey through health and social care. So I think we were very mindful, both in our literature review and in our surveys, to recognise that there is this tension sometimes between the brain disease and the science, and also what happens to families. Dementia happens to people, you know, living in their communities. It doesn't happen to just their brains. So that was really a starting point for our work around timely diagnosis with ALCOVE. So within the ALCOVE method, as Armel explained this morning, we did a large literature review looking at what was out there, both from a scientific point of view, searching primarily on Medline and PubMed, and then in addition looking at the more sort of psychological and social literature as well. And within our report on the literature, which is on the website, we looked at these 3 stages of the sort of mild cognitive difficulties, what we might call MCI, mild cognitive impairment, that timely diagnosis, and also later diagnosis. And we assessed the evidence for differential diagnosis at each stage, how we made those diagnostic classification decisions, the criteria for diagnosis of subtypes, so the more sort of technical aspects of what diagnosis was like at those 3 stages, but also then looking at who presents at each stage and who they present with, who they present to, how long it takes people to present at each of those stages, the barriers and the facilitators towards not going to see your doctor or going, and really trying to think, based on that literature, what processes should be delivered and by who, what are the key challenges, and what are the benefits and drawbacks. So that was the structure that we took for the literature review. And again, thinking about the ALCOVE method, we did a cross-country survey across member states who were signed up to the ALCOVE initiative, and after a lot of chasing, we got a pretty good return rates on some quite complicated questionnaires. And these were managed through, we divided Europe up into 5 European zones, and we had a sort of central person responsible for each of the zones for drawing back the information and making sense of it. I'm not going to talk about the method in great detail because I want to get on to some of the key recommendations. And I've put up some of the results from the ALCOVE survey there, which I think are pertinent to the recommendations. The stage of dementia at the time of diagnosis, for the countries that responded, they were saying most commonly we're making diagnoses now when the MMSE is around 10 to 20. So in that sort of moderate to advanced later stages. But we've got a significant number of countries, a small number, who were saying now we are currently making our diagnosis at an earlier stage when MMSE is 21 to 26. Most countries were saying they were missing a diagnosis of between 40 to 60% of theoretical diagnosis. Some countries were saying that they thought they had a misdiagnosis of only 20 to 30%, but they were the exception rather than the rule. And indeed, Scotland are up to 64% diagnosed now, are they? I was hearing this morning. So, you know, there is a variation across Europe, but it's a common concern that we know we're missing a lot. Almost half of the countries completing the survey already reported having specific policy guidelines in place to improve timely diagnosis. So this is already a policy initiative. Memory clinics and specific diagnostic services were known about in virtually all countries. So most countries had an example of specific memory service diagnostic services over and above the family doctor or specialist secondary care. But only 3 countries were reporting good geographical spread. And specialist diagnostic services, about 60% of the countries responding were saying that most patients they felt had access to specialist services. Our first recommendation when we were looking at the literature and what was happening from the different country perspective is that there seemed to be a convincing case for improving diagnostic rates and shifting that diagnosis typically to that being given at a mild to moderate stage, at a time when people first become aware of cognitive change, rather than the moderate to late stages. And in this table here, I've tried to summarise some of the benefits that there are to people living with dementia, of knowing at that mild to moderate stage, some of the benefits that there are to families, and some of the benefits that there are to health and social care economy. But there are also risks, and I think in terms of our recommendations, we were keen to make recommendations that would help balance some of those risks. And certainly these are ones that we know about the stigma and negative attitudes. If you're diagnosing early, you're more likely to get a misdiagnosis. So that's something in terms of our expertise and our systems around diagnosis. And not everyone wants to know early on. You know, we know that a lot of people, the majority of people, will say, it's my brain, it's my body, it's my life, I want to know. But some people may not. But likewise for families, isolation and stigmatisation. But also, I suppose, the risk for the health and social care economy. If we don't shift, then we'll continue to have services that are only available at late stage. So it's this tension at the moment between almost we've got to make the shift into earlier diagnosis and then the services will follow, rather than waiting for the services and then moving on. Okay, so Armel talked about these 4 cornerstone recommendations to try to ameliorate the risks associated with that. So our first cornerstone recommendation is that timely diagnosis should be available to all citizens who require it, and the all citizens is to cover, and the accessibility is to cover all sections of the community, recognising that if you're articulate, middle class, it's easier to get a diagnosis than if you're from a migrant community, or you've got younger onset dementia, or you've got a rarer type of dementia. That needs to go hand in hand with decreasing the fear and stigma about dementia, because if we continue with the fear and stigma and the myths that what dementia brings to people, then we won't get people coming forward for diagnosis, and we won't get GPs or family doctors who are willing to diagnose because of the associated stigma. And we know that the majority of countries were reporting that they had dementia awareness programs in place. I would query on some of our dementia awareness programs whether they increase fear and stigma or not, but it's about getting the right messages out there. that at timely diagnosis, the rights and wishes of the person with suspected dementia should be paramount in engaging with the assessment process used to receive the diagnosis. We shouldn't be forcing people to have a diagnosis or diagnosing people without their consent, you know. We're talking about early stage when people can make that informed decision for themselves. And certainly in practice, we know from our local work that some people, they don't want the diagnosis and they don't want it just yet, but they might want it later, you know. So it's about putting the power back with the person. And also recognising that the giving and the receiving of a diagnosis of dementia is a key intervention in itself. You know, this is a life-changing diagnosis, and how it is given and the process that surrounds that, we would hypothesise then has an impact on how people adjust to that diagnosis, and also how families adjust to that diagnosis. So it's not something that we'd want to be doing over the phone on a Saturday night. You know, this should be thought through about who's present, who hears, what's the language used, and all of the things we know about issues about breaking bad news. Recommendations developments. Within the literature review, we looked at detailed recommendations at the end of each section. We then had 5 phases of iteration with people with dementia, with family carers, and with a range of health and social care professionals. And certainly we were here at Alzheimer Europe last year and did a couple of workshops here around that. So we've used that iteration on the basis of the literature, the survey, and our workshops to develop this pyramid structure that builds on those 4 cornerstones. So those 4 cornerstones are our guiding principles for the further recommendations. And also in recognition that this is for EU, this is across all of the countries in the EU. So specifics about how we do it in one country, we're all starting from different baselines. So we can't be prescriptive about specific structures like should it be a GP or should it be secondary care, you know, but what we've tried to do is to build this pyramid structure, and it may be because Kareem Saad, who was on our team, is Egyptian, which is why we were so attracted to the pyramids. But we've taken these 5 key issues to build our recommendations around. First is the diagnostic process more generally, how that is made. Secondly is diagnosis in more complex cases. Thirdly, it's a set of recommendations about how countries should respond to those people in early cognitive change. So what we would sometimes call mild cognitive impairment, because it's a real shifting area, both in practice and research at the moment. Fourthly, in case detection and screening. And fifthly, we've separated out workforce requirements, recommendations around those as well. You'll see in your little brochure that there's one of the pyramids, I think, around case detection and screening. They look like that. You'll need your glasses on to have a good look at that. I put them up there just to demonstrate the shape of them, really. In the synthesis report, you know, if you get your magnifying glass out, you can really make out what it says. But for each pyramid, you've got the 4 cornerstones. So we're thinking about the diagnostic process. Those are our 4 starting points. But then building up to how that means that how the diagnostic process is managed. Once we're managing our diagnostic process, how information, advice and interventions are offered. Then to thinking about our sort of technical expertise in the diagnosis of classifications and subtypes. And then finally, a sort of the sophisticated pinnacle of what we should be aiming for within the diagnostic process. And just to prove that we have 5 pyramids, I'm going to put them up. Oh no, I'm not. I've not got time to talk about all that. Process of diagnosis, complex diagnosis, early cognitive change, timely detection, and workforce. If we follow that, you know, there's a lot of work involved both in ALCOVE, but the major work now is for all of us in bringing this to fruition. But, you know, for this family, they should get an accurate diagnosis of dementia at a time when they have the capacity to make plans for the future and optimise their chances of living well with dementia. That they don't feel that they'll be stigmatised about having a diagnosis of dementia, that they're realistic about the future and they're facing it with valid information. And that if their health and social care professional identifies that they may have a dementia, they are in control of when they go forwards for diagnosis, how they engage with the assessment process and how they will receive that diagnosis. And that the diagnosis is given in a way that helps this family adjust to this changed perspective on their life. That they and their family then have the help and support post-diagnosis to be of benefit to them, you know. And this phrase, I think, is a useful one, that when people have that timely diagnosis, it should illuminate the pathway, not be their exit point from services. Okay, thank you very much.